Hey everyone, my name is Cheyenne. Thank you so much for joining us this Sunday evening. Um, just wanted to quickly go over what PhysiLink is and what this initiative is about before we introduce Dr. Pradhan. So, pretty sure you can see my screen. PhysiLink is an online program that a couple of students at USC have created. The whole idea is to connect everyone with various specialties and hopefully develop some kind of mentorship relationship. We'll also have webinars during the month, at least two, one with a physician and one with a resident. And then we'll also post those webinars on our YouTube channel as well as on our podcast. And so this is Dr. Pradhan's page. As you can see, we have a physician and resident page. And here you could ask her any questions you would like to anonymously. And at the end of the month, we'll get those questions answered and posted on our page. And so if you have any questions that you weren't able to get answered during this webinar, I highly encourage you to go here and type your name, email, and question, and then you'll see your question pop up right here. And so we'll also have a physician webinar. This one is with Dr. Winkler, and it'll be tomorrow at 7 p.m. If you're interested, you can head over to our website and click on this button to register. This will kind of be a similar format, but we'll also have a case study at the end where he'll go over different things and pictures that he's seen in the emergency room. And then once again, you can also ask any questions right here until the end of the month. I'll drop the link in the chat. You could also go through previous physicians, go through all of their information, and also look at their webinar, as well as the questions that they've answered. To sign up and join this initiative, you have to go to the newsletter webpage and type in your name and email, and then we'll be sure to update you with everything. And then you could also check out podcast episodes and webinars on the webinar and podcast page. So I'll drop that in the chat real quick. So be sure to join our webinar tomorrow as well. All right. Now, let's get started. So we're delighted to welcome Dr. Sasya Pradhan to today's webinar. Dr. Pradhan is a dedicated neurology resident at Prisma Health Hospital in Columbia, South Carolina. She earned her medical degree from JJM Medical College and is currently completing her neurology residency, where she's known for her commitment to patient care and enthusiasm. In addition to her work as a physician, Dr. Pradhan is a passionate blogger and an animal lover, bringing her creativity and compassion to every aspect of her life. We are thrilled to have her share her insights and expertise with us today. So Dr. Pradhan, if you don't mind just adding to this introduction and just introduce yourself and fill in anything I missed out on.
Hi, everyone. Thank you, Sham, for giving me this opportunity. I'm Sasya Pradhan. You can call me Sasya. I'm an IMG. I did my med school back in India, and I'm here for my neurology residency. It's been a quite interesting journey to start with. The curriculum back in India and here is completely different. So I've had my ups and downs, and I'm here now in front of you. So if you have any questions, just ask me anything that I can help you with.
Great, thank you so much. So with you being our first resident feature on this platform, I guess we could just start with the question, what does it mean to be a resident and how do you get there? Like what are kind of the steps and I guess tests that you need to do to get there?
Mm-hmm. Once you're done with your pre-med, I think you give your MCAT, and once you get a good score, you apply to pre-med school, and after finishing med school, you join residency. So basically, it's like a graduate training after your med school. It depends on, it lasts for like 3 to 5 years, depends on what specialty you choose. I'm in neurology, so my residency is for 4 years, and internal medicine is for 3 years. Ophthalmology is also for 3 years. So once I finish my graduate training, that is residency, I get to apply for fellowship, or I can go and work as an attending. So I have had many my seniors in the past who directly went and worked as attendings after residency, and many of my batchmates chose the fellowship pathway. Fellowship is basically super specializing in the field you chose. For example, I'm in neurology and I get to choose stroke, epilepsy, neuroimmunology, MS, neuro-oncology, and all the subspecialties as my fellowship options. So, based on your personal preference, you can go ahead with your choices.
So with uh, applying to be a resident, is it kind of a similar process to, I guess, how we apply to med school? And I guess that would be like essay writing, having letter of recommendations, and then do you have to take the step one, step two, and get certain scores? Like what are the qualifications there?
Yes. So applying for residency, you need to pass USMLE step 1 and 2. I think DO students give complex exams instead of USMLE. They also have 3 exams. So it's either USMLE step 1, 2, and 3 and complex 1, 2, and 3. For USMLE, I did USMLE because I'm an MD from international country. So I can't give complex, and you have an option of giving step 3 after once you join the residency. So basically you have to clear those 2 exams, and along with the good step scores, you need to have letter of recommendations from where you rotate. You can ask your attendings for letter of recommendations. I think you need to give at least 3. Some people do submit 4 too, so make sure that you have 3 to 4 LORs. And they look at your CV, like overall, they look at your research. If you have done any research while you're in your med school or in your gap year, they check about any publications or posters you have done before. They'll check about your hobbies, everything. It's like not just academic, they look through your personal profile too.
Gotcha. So now that we've gotten that out of the way,
Mhm.
I guess let's talk a little bit about general neurology before we kind of go into those specialties that you mentioned as well. What
Mhm.
is neurology exactly, and what cases do you typically see from day to day?
So, neurology, as a neurologist, I deal with all the diseases attacking the brain, nerves, and the spinal cord. So, we have a huge amount of stroke here. So, we see almost 10 to 20 strokes each day. And we see many seizure patients here. We see multiple sclerosis, which is a demyelinating disease in the brain. We see, like I said, lesions like glioblastoma or any tumors in the brain. We see patients with tumors in spinal cord or demyelinating lesions in spinal cord. We see patients with neuropathy, which is a disease of peripheral nerves in the body. And we see patients with movement disorders like Parkinson's. We see patients with Huntington's, which is also a kind of movement disorder. So anything that affects the brain, spine, and nerves comes into neurology.
So some of this seems more like emergent care, while some of it could be like long-term management. So do you look at both, or is there someone who specifically looks at emergency cases?
So, as a resident, we get trained in both of them, both emergent and outpatient care, if that's what you're asking me. Most of the emergent neurology cases are usually strokes and seizures too, because if someone comes in status, those are also considered emergency. So, we get stroke alerts whenever a patient come in within maybe 4 hours of symptom onset or 24 hours of symptom onset. Whenever we get the stroke alert, we run to the ED. We look at the patient, we evaluate the NIH score, and this is important because we have to determine if patient is qualified to get a intravenous thrombolytic, like a clot busting medication. So the most common cause of stroke is due to the loss of blood supply to the brain, right? So if there is a clot, we give a medication to break the clot. So basically, we're trying to figure out if the patient fits in within the window or not. We have a whole criteria, and that's a life-saving procedure. We have seen patients coming with total paralysis, like half of the body. We gave the medication within maybe 6 hours. They're moving all the legs and hands, and they walk out of the hospital. So It's very good to see such cases because you know that you're making difference in their lives. Not all neurological symptoms can be treated that way. So seizures and stroke are something which can be treated acutely in emergent cases and with a good chance of patients walking out happily. And
Yeah, that's
the non,
incredible.
yeah. So the non-emergent cases, like I said, are MS, movement disorders, and everything. You get to see these patients mostly in clinics. You follow them up every 3 to 6 months based on the acuity of the situation, and they message you through my charts and stuff. So you stay in touch with the patients, all of your patients, and you change the dosage of drugs on the electronic medical system. You don't have to see them every time you change the dosage. So you keep in touch with them every now and then through messages, and you deal with the non-acute cases like that. So the
Yeah.
career options involve choosing the non-acute option and the acute options. For someone who can't sleep well, they tend to do outpatient more. So I chose epilepsy as my fellowship. I can opt for just seeing patients in the clinic, not to get involved in the acute stuff in the hospital. And the neurologist who stays in the hospital manages patients in the hospital. They deal with the status, they stabilize the patient, and then they send the patient to me in the clinic, maybe after 2 to 4 weeks. And then I carry over from then and decide to stabilize the seizures and epilepsy.
So with a lot of these acute and emergent cases, how much autonomy do you have as a resident? Can you kind of take the patient under your wing and administer everything, or does this change during your, maybe when you're starting off as a resident versus when you're ending as a resident?
So our program gives us great autonomy, which I'm very thankful for because I think that that's how you learn. You need to see many patients, do what you want, and that's how you learn. You make mistakes too. You can't avoid making mistakes. So in initial years, PGY2, we always have our senior with us. So they'll be guiding us throughout the procedure and throughout decision making, and our attending will be monitoring the whole process. Uh, and as you go up, graduate up to the upper level, once you're a PGY3 or PGY4, you get much autonomy, and the attending will ask the senior what they want to do. So it's basically the senior taking all the decisions for treatment of patients and attending approving it or making minor changes. So the autonomy as a PGY2 is less because they want you to prove that you're competent enough to take care of patients alone. So once you're done with that few months, you're left alone.
So you're still under an attendant though, like so in terms of like liability and everything, if you do make
Yes,
mistake,
yes,
the attending would cover you.
yes. All the orders have to be co-signed by my attending, so I can't do anything alone. Yeah.
Gotcha. And so I used to think that residency was just, I guess, kind of a med student who just finished and then kind of just goes and works in a hospital until they've gained enough experience. But I recently learned that there's like some structure to it. So can you kind of talk about, what you do every single year, and then are there exams or tests or anything that you have to do, or what is there?
So you don't have to pass step three, right? USMLE step three to join residency. Most of the residents tend to complete the step three in the first year of training. So I did my step three in the first month of second year. So you're expected to complete the step three by the end of second year. That's for neurology. I'm not sure if it's the same for internal medicine. So once you're done with that exam, you have every year in-service training exam. Basically, they're training you to give the boards. The question stem are similar to board exams, maybe a little bit longer, and it's basically self like NBME shelf exams for the residents. We get to do it every year from second year for neurology residents, and I think it's the same for internal medicine too. And once you're done with the rights, you give the boards once you graduate, and yeah. you become an attending.
So the boards are the standardized tests, and then there are internal tests or exams that like your residency program does. Okay.
They're
And do
basically
you have
like practice tests. They give you a percentile score, so it's just like USMLE. You know where you stand amongst the other neurology residents in the country.
okay. So do you still have like lectures and professors, or
Yes.
is it kind of on the job learning?
We have a good academic program structure in our program. We have lectures every morning and noon. We have resident lectures, we have attending lectures, we have people from Mayo giving us lectures sometimes because we don't have a neuroimmunologist here. So whatever specialty is not available here, we tend to ask people from outside to give us lectures.
Gotcha. And then is this how you learn about different subspecialties? Like as you mentioned earlier, there's a ton of fellowships that you could go into. So how do you kind of get exposed to all those fellowships, and how do you get the experience to know which one is best fit for you?
As a resident, you get to do both inpatient and outpatient, right? Uh, I think in the initial years for electives, you have to choose more outpatient blocks to be able to figure out which you like more. Some people like to work in the hospitals. They like to admit the patient, treat the patient, see them get better, discharge them, and let them go, not follow them up in the clinic. But some people prefer to have more relaxed life, so just do the outpatient. So you will definitely get plenty of inpatient experience once you go into any type of training. But the only thing I would say is make sure to get more outpatient exposure too, because that's how you can choose in the future. Some programs do not have very strict layout about how many outpatient blocks they give to the residents. Uh, Many programs should be flexible. If you ask them, they should give you outpatient blocks. So make sure that you ask them and get your outpatient blocks, because that's the only way, you know. I joined residency thinking that I will be a stroke interventional neurologist. So I wanted to do the mechanical thrombectomies. I wanted to do that, all the acute stuff. But once I did my first year, we have 2 months of inpatients in neurology in the first year. So once I'm done with the inpatient blocks, stroke kind of scared me, because not every patient walks out right. You have to deal with them having the weakness, them developing bed sores, them developing depression. It could go anyway. You will have a like 80-year-old not being able to move like half of their body, and it's sad to see. I couldn't do it. And then in my second year, initially, I had a EEG block. EEG is like a study like a EKG of heart. You put stickers in the brain, you basically measure the brain waves, and that's how you see if someone is seizing or not. That's what epileptologists do. And once I was done through that rotation, I just fell in love with reading EEGs, and I knew that that was my thing. Maybe it was kind of a calling, maybe. uh, I'm a person who likes to see my patients improve, so I don't mind doing both. I'm looking for a job with a mixture of both inpatient and outpatient. So it all depends on you and your personal choice. And I think people can get any kind of job in the future. You just have to ask the hospital about the inpatient and outpatient weeks, and they'll give you, and you can set it up with them. I think it's quite flexible. We have attendings who do only inpatients the whole year, and we have attendings who just be in the clinic, not come to the hospital and round with us at all. And we have attendings who do both. So it's pretty flexible, and you have multiple options.
Yeah, it's good to hear that even after you have selected a specialty and started a residency, you could still kind of find your niche within the specialty. All right, so kind of moving on, or I guess before we move on, if anyone attending has any questions that they'd like to ask, feel free to just drop it in the chat, and I'll be sure to add it to my list of questions. We only have a couple more that I have, so I encourage you all to ask any questions. All right, so kind of moving on to how your day to day or week is structured. Um, I guess what does a work week look like for you? And are you on call or how does that work?
So in second year, you spend a quite lot of time in the hospital. I was an IMG transitioning to my life in US here, so it was very hard for me initially. And I used to stay for hours together after work in the hospital, just trying to figure out how to deal with things, how to finish up my notes, how to trying to be more efficient. So once I dealt with that transitional period, I get to leave at around 6 or 7 in the evening when you're on service. This is when you are admitting patients, like taking care of them, discharging them, the inpatient work. You go at 6 in the morning, you take checkout from the night resident who saw all the patients during the night, and you take over care for those patients and you wait till 6 and the night resident comes back and you hand over the care to them and go home. And if you are a AMJ, it's comparatively easier because you would be more aware of the electronic medical records and Epic and all the stuff uh, when you train through the med school here in US. So it should be an easy transition, and you should be able to get off work by 6 for sure. And once I come back home, I try to like cook or do laundry or get groceries and all the other stuff.
So is this Monday through Friday, or you also work the weekend?
This is Monday through Friday. We had multiple changes in our schedules. So currently we have one golden weekend and one black weekend. In the golden weekend, we have both Saturday and Sunday off. So you go home at maybe 4 or 6 on a Friday, and you have the whole weekend off, and you come back at 6 on the Monday. Now, this weekend I was working, so I just came home from work. Uh, Today it was not too bad. So on the weekends you're working, you stay till 6 until the night person comes.
So you mentioned there being a night resident. So how does that
Mhm.
work? Do you have to like sign up for certain night shifts?
Yes, we all have 2 blocks of night duties. So, and as you graduate to upper levels, it gets to 1 month for the whole year. And as a junior, you do it for 2 months. You come in at 6, like I said, take over care for all the patients. So we get brief summary of the every patient's on our list and the important things to be done, important scans to be checked, and it's basically covering service for the whole teams. So we have 2 teams in the hospital. When you're in service, we have a stroke team and a general team. Stroke team takes care of stroke patients, deal with the stroke alerts, and general team takes care of all the other neurology patients. Uh, the night person is kind of in charge for both the teams. Whatever questions nurses or other hospitalist team or any other doctor gets on these patients, the night residence is responsible to answer the questions. And they also take in the new patients that come and they admitted to our service. So it's basically handling all the patients on the list and admitting the new patients overnight.
Got it. So when you come in the morning, the first thing you do is kind of get debriefed from the night resident, and then you go kind of maybe check on the patients, and then
Mhm. I'm a
I guess
senior
like
now, so I
classes.
don't go check on the patients early in the morning. So the juniors go and check on the patients, they come back, and then we discuss how the patient is, if the patient is stable or if they're declining or if they're improved. Based on that, we decide about what should be done. Our goal is to send the patient home as soon as possible. So admitting patient is a very small thing. Completing workup is a major part of the patient care. And once we complete the workup, we get the case managers and social workers involved so that patient can be discharged home as soon as possible. For patients with stroke who have like a dense hemiparesis or one-sided weakness, they can't walk, right? So they can't go home because they can't walk, and they need someone to take care of them 24/7. Such patients, we send them to rehabilitation center, and for that to be possible, we need to get the insurance approved, and they come in with different insurances. Some people won't even have an insurance. So our case management takes care of all the stuff. And once we get a bed in a rehabilitation center, we send them out. We, we all know about hospital acquired infections, right? So our goal is to send patients out as soon as possible. And most likely we book a follow-up with them, with us. If I see like 3 patients on the list today, I tend to follow them up in my clinic so that I have a continuity of care. That's how residence clinic work. uh, and once I see them in the clinic, if they're stable, I follow them every 6 months. If they're still not improved, if they're still having seizures, I see them every 1 month or maybe every few weeks until they get stabilized. And once we deal with all the work in the hospital, uh, after lecture, we get to have a lunch break for an hour. And we just type in our notes, trying to finish all the work so that we can leave early. And once I come home, before coming home, we give the debriefing again to the night residents and come back. That's basically what we do the whole day. We also have electives, the outpatient blocks I was talking about. Uh, if you ask me, electives are much easier. You don't have to go see patients in person, you don't have to admit anyone. And the work involves what kind of elective you're in. For example, in neurology, I can do an epilepsy elective. I can do a multiple sclerosis elective. I can do a research elective. So we have 3, 4 different trials going on in our neurology research department. I can just choose one whole month of research, go work with them, enroll patients in trials, and just help with the statistics and be done with it. That month, I get to leave at 2 o'clock if I'm done with the work. So it's very flexible, and it depends on what you do in those elective days. If I'm in epilepsy, I usually follow the attendings epilepsy clinic. Attendings usually work from morning 9 to evening 4. So I tend to stay until the last patient is there. And once they're done with the last patient, then we get to leave. During electives, it's basically pretty chill. You can go home by 4 max. And when you're on service, you are responsible for all the patients until 6. It's not as bad as you think.
So earlier you mentioned how you're like a senior resident and the junior residents report to you. So is there like some kind of I guess like leadership component where you're managing a team and then you report to the attending?
Mhm. So we have maybe 2 juniors on each team. We have 2 teams, right? Like I said, stroke in general, and we have 2 to 3 juniors for each team and 1 senior for each team, and an attending who works with the whole team. The juniors go see the patients, and they tell us the whole story, and they give us an exam, and we kind of come with a plan, and we discuss that plan with the attending, and they give a nod. If everything is good, they say yes, and we continue with the plan, or else we make minor changes. So as a junior resident, your main focus would be on examining patients, getting good histories, getting good at history taking, because that's very important, and getting seeing as many patients as you can, and strengthening your examination skills and clinical skills. I feel that the more patients you see, the more exams you do, you learn a lot. In medicine, patient teach you a lot, even rather than an MCQ question bank or a textbook. See as many patients as you can, and you'll learn so many things. Even for example, for seizures, someone will come with seizures just because they're not taking medications. Someone will come with seizures because of some lesion in the brain, be it a tumor or a stroke, anything that affects the brain, scars the brain, causes seizure. So management of a seizure might be the same, but it also depends on what is the underlying condition that's causing the seizure. So each patient has a different combination of stuff going on. So you learn a lot. So as a junior, you have to be doing that, and as senior, you have to concentrate more on knowing all the patients, supporting your junior, like leadership, and making sure that the workflow is good, and helping out the juniors when it gets busy. It's more of a intellectual work rather than physical work. And I would say that juniors do more physical work because they're the ones who sees the patients and write the notes.
Yeah, that makes perfect sense. And that's kind of how you, I guess, develop different skills at different point in your residency. All right, so we have one more topic before we go through the questions in the chat, and that is compensation. You can kind of be as detailed or general as you'd like to, but I guess the general word on the street is that like residency compensation is just enough to get by until you kind of become an attending. Just wanted to see what you thought of that. And yeah,
You mean the salary wise?
it could be salary, yeah, and yeah, mainly salary.
Residency, you don't get paid too much. It's usually ranges around 50K to 90K, depending on where you are. In New York, the cost of living is high, so they get around 90K. And in other states like South Carolina, North Carolina, we get around 50 to 60K. And as an attending, it improves a lot. I can say that for sure.
So does that depend on, I guess, the number of hours you work, or is it kind of like a fixed number?
It starts with a fixed number. If you see, if you work in a hospital, like a hospitalist general neurologist who gets to see all type of neurological issues or diseases, you get paid less. If you specialize and if you can read EEGs, if you can do procedures, you get to earn more because each procedure you do, you can charge for the procedure, and that's how you build up your RVUs and salaries. And it depends on where you work to. If you work in a suburb area, not a big city, you get paid more, and big cities pay you less. So there's so many
And
things.
even as a resident, will it vary based off of like what you're doing that year or how many hours you're working or overnight?
No, nothing affects. It's a standardized salary pay. I can say that. Nothing will change it. Some programs do allow residents to moonlight when they are in final years, like a PGY or a PGY3. Moonlight is basically going to some other hospital which is affiliated to your hospital and taking shifts over there. Mainly ED residents do that, and I heard that they get paid somewhere around $500 to $800. And during COVID times, they got $1,000 too. We are not allowed to do that. It depends on the program. Based about the fixed pay grade, if you are allowed to moonlight, you can earn more.
But basically, as a resident, you're kind of at a fixed rate during
Yeah.
all 4 years, regardless. Okay.
They increase it every year, like maybe by $1,000 or so, but not much.
Okay, that makes sense. Thank you. All right, so we're gonna go to the first question in the chat. Do you have any experience with pediatric neurology? I guess if you could also talk about how that works in terms of residency, like if you have to do pediatric residency first.
Mhm. I'm an adult neurology resident, so we get to do 2 months of pediatric neurology every year, starting third year. So in the last 2 years of training, we get to do two each. So we have 4 months of pediatric neurology experience. Again, as an elective, you can still choose to do more pediatrics, opt to follow pediatric neurologist in their clinic or read pediatric EEGs. So you can get maybe 4 to 6 months in the last 2 years. That's a good exposure. I had, yeah.
So can you do a pediatric residency first and then do neurology after, or is there like one path where you have to do neurology and then do a fellowship in
I don't think
pediatrics?
you have to do neurology. You can do pediatrics and then opt for pediatric neurology as a fellowship kind of a situation. If you opt for pediatric neurology, I think the first 2 years or first 3 years will be pediatrics and the last year will be neurology. So it's little different from that neurology pathway.
And would you say pediatric neurology is a lot different from adult neurology? Is it
Yeah,
kind of
it's
the
a lot
same?
different. Yeah. We see more strokes on the adult side, and in the pediatric neurology side, it's more of a viral induced demyelinating disease or viral induced confusion or infection of brain. We do see strokes too. Mostly it's headache and viral conditions or seizures or developmental diseases, because of which they get seizures or developmental delays. We also see patients with tic disorders and movement disorders and behavioral disorders. So it's completely different from what we see in neurology.
Okay, that makes sense. All right, moving on to the next question. Do you know if becoming a psychiatry resident is similar to becoming a neurology resident when it comes to classes taken in med school and the application process?
I wouldn't be a good person to answer that question because I did my med school back in India, so I'm not very sure about that particular question. Sorry.
But psychiatry resident is completely different from neurology
It's
resident.
completely different too. We have had a psychiatry resident in the past, maybe I was told 5 years ago. He came and rotated with us. He liked neurology much better than, I mean, more than psychiatry. So he dropped out and he matched again. He applied again to the match and matched into neurology. So psychiatry and neurology work pretty close with each other. We do have psych residents, especially in their initial years of training, coming and working with us. I have a psych resident right now who's working with me on the stroke team. Uh, yeah, so we work pretty close. They come and give us lectures about commonly diagnosed psychiatric diseases in neurological patients, and we go give them lectures. And I think even the boards are combined. It's boards for both psychiatric and neurological disorders. Yeah, it's quite, yeah, we do see a lot of psych patients too in our service.
So with a psych resident on your team, I
Mhm.
guess what role does he or she have, and what role do you have? Like, how does that differ, and what's the approach, or how does the approach differ?
They see all the patients that a neurology resident would see. It's basically, it doesn't matter where they're coming from, which specialty they're coming from. Once they're on our service, they're neurology residents. We treat them like that. But the number of patients they get to deal with is comparatively less than the neurology residents. So for example, if we have 15 patients on the list, we give 10 to the neurology resident and 5 to the psychiatry resident, so that they're not overwhelmed and they can learn neurology too. So I think in the final years of psychiatry residency, you get to go shadow attending neurologists in neurology. So the outpatient exposure, you can get it in the final year. And we also go and rotate with the psychiatry department. Uh, I did my psychiatry rotation in PGY3, if I remember correctly. So I had 2 months of psychiatry. It's pretty interesting.
This is mainly dealing with psychology disorders and symptom management for those.
Yes, depression, mania, schizophrenia, overdosing. We see a lot of overdosing in our hospital, and suicidal ideation. So if you see anything acute, you hospitalize them, and once you deem them to be safe, then you can send them home.
Okay, got it.
I think
All right.
psychiatry is more outpatient, if you ask me, because you get to see them. Therapy is the most, I mean, psychiatry involves therapy, right? That's the main thing. It's not very heavy inpatient wise, if you ask me. So most of the psychiatry attendings work outpatient, and very few psychiatry attendings work inpatient.
Okay, perfect. That was going to be my next question. All right, so now we're gonna. Someone has asked a little bit about the matching process. I'm not
Mhm.
sure if it is different for an international medical graduate, um, but if it's kind of similar, the same, could you just talk a little bit about that?
Yes. It's pretty similar. We complete all the steps and then we go to the website, we apply with our scores. I came and rotated here in Kansas City, University of Missouri. I came through my med school when I was in my final year. So I did 3 rotations in that particular university. And after that, I did a few observerships once I graduated from my med school back in India. So I had 5 months of US clinical experience. And with those 5 months, I got a letter of recommendations from each attending. Even in every month, the attendings change every week. So you get to work with 4 different attendings. And if you build a good rapport with them, each of them can give you a LOR. So that's how you build connections and get LORs and stay in touch with them. And you upload those LORs, minimum 3, and you can upload 4 too. And with that, I think the application also asks you about your research, your prior publications, and your medical school performance evaluation. Your dean gets to write how well you did in each of your rotation. It's like a full comprised list of all the rotations that you did. That's how it was for me. Um, you get to submit that, and there's also a section about your hobbies. So, like I said, it's not just your academic profile. They also uh, check your personal stuff, your hobbies, your personal growth. They also ask if you're interested in traveling. I mean, they ask you to just describe your meaningful experiences in life. So that's a section in the application, for example. And you can write about your traveling if that was meaningful to you, if that has made impact in your life, not just the academics and your work stuff. So it's like they look at everything. Like it's a person as a whole, because even if you're smart, if you don't have a good personality, if you're not a team worker, on longer run, you can't be a successful resident. So they try to get people who will go in with their team, and who is a team player and who works well and who is friendly enough. Basically, a person with a good personality.
Yeah, it's good to hear that they have kind of a holistic approach to selecting residents. So, in terms of the actual matching, my understanding is that you kind of submit a ranking of different residency programs.
So once we fill out the applications, we send applications to different universities, and the number of universities you apply to differ. As an IMG, I had to apply to 200 programs, and I think AMGs apply to just maybe 30 or 50. I've known people who applied to 10 or 20, and they ended up matching. And you select the programs based on your preference. Uh, if you're okay with any state, you can apply to all programs, or if you have family in one particular state, you can apply to all programs in that state. And once you send out applications, they give you interviews, and then you go. My all my interviews were virtual. I did everything from back in India. COVID was going on. So I was one of the COVID candidates. And if you're here, I think even now the same ritual is continued. It's all virtual now. Some programs do ask you to come in person so that they can show you around. You can also meet the team of residents and attendings you're going to be working with the before night. We call it a pre-interview dinner, and that's where I don't think attendings will come to that dinner. It's just the residents and fellows. You get to ask them all the questions, and the next day you go meet the attendings, the program director, program coordinator. They give you a brief review of curriculum, and they walk you through the hospital, and the interviews will start. And you typically interview with 4 to 6 attendings, depending on how big the program is. I have interviewed with 8 attendings once. That's for my fellowship. I think for residency, it won't be more than 6. And once you interview with all of them, if you like the program, you rank them high. So, rank order list is basically you telling the uh, NRMP that you like this program the best. And you just give a rank order from 1 to 10 or 1 to 20. And based on your rank order, if that program also liked you, if they also rank you high enough, you match there. So I think it's based on your preference. If you rank X program, and if the X program has ranked you in the first 4 or 5 positions, you'll go match there because they are your first choice.
So it's really up to you and your personal preferences and what you've seen at that residency program for you to pick. Okay. Um, and we have one more question. What advice would you give to a medical student transitioning to residency? What are some things to look out for and keep in mind? And I guess how was that transition?
Take it light and don't get tensed. Even if you have a gap year, it's fine. Just use that gap year to build up your application and strengthen your application. Maybe improve your GPA or MCAT score if needed. You can follow or shadow attendings in hospitals just to gain more information about or experience about how residency is, because everything gets added on your CV. I've seen we have 2 pre-med school students in our research program. They do volunteer, they do help with statistics and stuff. And I know that one of those 2 persons, she's applying for med school. She wants to she wants to become emergency medicine resident. So she's going to apply to med school soon. So we have had many students coming in just to see if this profession suits them on.
And would you say the skills that you developed as a medical student in terms of like time management, maybe like high pressure, lots of volume in terms of what you need to know, those skills kind of transferred over to residency and were just as helpful?
Yes.
Or was there a lot of adjustment from medical school to residency?
Like I said, my transition was a bit harder, but if you are trained in American medical school, it should be easy. As a med student, you get to stay in the hospital as long as the resident stays. Sometimes you can leave early. So basically, you finish work at 4, but we stay till 6 because we have to check all the orders, we have to write all the notes, we have to make sure that all patients are stable, and then we leave home. But medical students can leave at 4. You're basically having a taste of what residency feels like, but it's not the complete workload. So you'll know once once you're a med student, and the transition should be easy.
Okay, so medical students kind of live the life of a resident, at least in some capacity, so that when they do transition, it's
Especially when you're in surgery, I think you'll do overnight calls too. Even in medicine, you stay in the hospital the whole night with the resident, just shadow them, go see patients with them. So you get a taste of how the night duties are too.
okay. Got it. And then we have a question on what are important considerations when
Actually,
choosing?
fourth year med students are considered as PGY1 sometimes. We also have acting interns. For example, if a medical student is interested in neurology, they get a rotation of acting internship. and they come to our program and they write notes. They work as an intern, like a PGY1, or attending signs the notes. They can't put in orders, but they do everything. There won't be any junior resident at least, who's taking care of that patient. So it's just them and the senior resident. So you get
Is this something that's set up by the medical school or something that I can kind of
another
reach with this place?
Yeah.
Okay.
We've had students from Augusta too, who did acting internships here in our program. In Colombia, I think you can go to other universities and do the acting internship too, especially when they don't have enough neurology exposure. I think you can ask your program coordinator or someone to go to some different program and do it there.
Okay. And this is primarily during like the third and fourth year medical school where you have
I don't think third, but the final year.
got it. Um, then there's a question on what are important considerations when choosing a residency match program. I think we went into that already. You primarily said it was like based off personal preference and I guess the certain things that you're looking at in that residency program, right?
Yeah. It also it's 100% your personal preference. For example, for my fellowship, I chose to work in a heavy program because before I become an attending, I wanted to see as many patients as I can. I wanted to get the work, how much of a workload it is. I wanted to be my best before I graduate from a fellowship, before I'm alone dealing with the patients. So it all depends on your confidence level too. If you want such kind of exposure, you can apply to programs which are quite busy. And if you are more towards, I want to balance my work life and personal life, you can opt for such programs.
Got it. And then next question we kind of already talked about as well, the different aspects of residency applications. You do mention that it was kind of a holistic approach where they talk about, what you enjoy doing for fun, your hobbies, as well as your research experience, rotations, and then letters of recommendations are also a big component.
Physician
That-
fatigue is real. So, especially after your first few months of service, you will be fatigued. Maybe you'll question yourself, why did I choose residency? So, have your hobbies. That's how you can escape from the life you have in the hospital. I think attendings do look at that aspect too. So, it's important to have your hobbies and continue doing it.
Yeah, I think wellness is a big topic nowadays. It used to be stigmatized, but people are kind of trying to work to make it something that we could all talk about openly. I guess based off of that, do you mind just kind of sharing what strategies you use to maybe avoid burnout or, as you said, physician fatigue?
I'm one of the wellness chiefs here, so we make sure that we go out, we meet every now and then. For example, after finishing a service month, we might go out for a few drinks or a few tacos, and then we do get funds for our wellness. We get to choose how we spend the funds. Every year, we choose some activity. Like last year, we went to Dave and Buster's. So we had a whole night of activities. We played games there. And the year before that, we went to an amusement park. So we do have funding from the program, and we do have multiple options through Prisma Health, because I work under Prisma Health, right? So they give us free therapy sessions. If you are feeling fatigued, you can link up to a psychiatrist and or a therapist and talk to them about what you're facing. You can, yeah, we are well supported. We have good resources on the website too.
Yeah, it's great to hear that there are initiatives embedded in the residency program as well, so you could kind of take care of yourself. I have one last question, and I know you mentioned them earlier, but if you don't mind, what are the different pathways after residency that someone could take for neurology specifically?
You
And I guess
mean
this is just asking about fellowships or like a subspecialty within neurology.
Yeah, so you can opt to be a general neurologist. So you work in the hospital, see all the neurological diseases and all the patients without any uh, differentiation and treat them and send them. You don't have to follow them in the outpatient. That's called hospital neuro hospitalist. So such jobs are called neuro hospitalist. Basically, you're just working in the hospital. And we do have fellowship options. We have epilepsy, we have neuro-oncology, we have neuroimmunology, which covers all the demyelinating and autoimmune diseases. We have movement disorder, we have sleep, we have neuropsychiatry, we have what else? I'm blanking out. Yeah, these are the most common ones people usually apply to. And the fellowship depends on the branch you take. I have an option to do 2 years of epilepsy, or I can just do 1 year. If I want to train myself in the surgical epilepsy part, I have to do 2 years. Or if I want to do more research in that area, I can do 2 years. So it depends on what you choose. For example, you can go to stroke, do the 1 year stroke fellowship, and be done with it. If you want to do stroke and also intervention, you do stroke and then do 1 year of interventional training. So that's a total of 2 years. And then you can become the attending. Uh, just see the stroke patients in the clinic and maybe do 2 weeks of uh, neuro hospitalist work. So you can mix and match and you can choose based on your preference.
And it seems like there's a ton of options to choose from. So I guess you have to
Yeah.
really do some exploring. Yeah.
Mhm.
All right. So now we're approaching 8 o'clock. So is there anything else you'd like to share before we wrap up? And most of these people that are attending are pre-med students currently in undergrad.
Mhm. If you can, I recommend going and just spending time with residents, just observe them for a week and see if that's your niche or not. Uh, I, I think that's a good way to start if you're considering becoming a physician and entering a med school. And I would also do my financial preparation because you all know that med school costs so much. So if you have a gap year, I would work on building that aspect of your life. But if you do have a chance, do go and see observe how the physicians work in the hospital.
All right. Well, thank you so much for taking the time to share everything that you've learned as well as your experiences. Everyone else attending, that kind of is the end of our webinar. Like I said earlier, if you have any other questions, feel free to input them into our website, and then we'll be sure to get those answered by Dr. Pradhan by the end of the month. Otherwise, we'll submit this webinar recording to our YouTube channel, and we'll also have a podcast episode posted. If you have any other questions, feel free to reach out to me or the PhysiLink email on our website. But if not, thank you so much for attending and have a great rest of your night.